Every year, more than 5,000 Americans are diagnosed with a fatal neurodegenerative disorder known as amyotrophic lateral sclerosis, or ALS. It is also widely known as Lou Gehrig's disease, named for the baseball player whose diagnosis brought it to public attention. But the onset of this disease is rarely marked by sudden catastrophic paralysis. Instead, it begins with small, painless anomalies that are easily brushed off. You might trip on a rug, drop a coffee cup, or notice a muscle twitch in your hands or tongue. Because these signs are so mild, the disease operates unnoticed. The physical decline takes root well before the patient even knows they are in danger. This chart breaks down case origins. 10% are inherited or familial. The remaining 90% occur sporadically, without a clear cause. Looking deeper, sporadic cases most commonly target individuals aged 55 to 75, men under 65, and those who smoke. There is also a distinct statistical anomaly. Military veterans show a notably higher risk of developing ALS. Researchers suspect this correlation is linked to physical trauma or exposure to environmental toxins during service. Early symptoms mimic a vast range of other conditions. Reaching a conclusion requires a wide battery of blood tests, urine screenings, and MRIs to systematically isolate the true cause. Once other conditions are ruled out, clinicians use specialized tools like electromyographies and nerve conduction studies to test muscle activity and measure the strength of the nerve signals. Confirming an ALS diagnosis is a painstaking process of elimination that refines a vague series of physical quirks into a definitive, life-altering verdict. To understand how this happens, we look deep inside the body's circuitry at the motor neurons, the vital biological pathways that regulate all voluntary movement. Upper motor neurons travel from the brain down to the spinal cord. Lower motor neurons extend to skeletal muscles. In ALS, dysfunctional proteins accumulate and cluster inside these specific neurons. As these pathways clog, neurons progressively deteriorate and die, acting exactly like a severed telephone wire. The brain itself continues to function perfectly. It sends urgent signals to move, but the target muscle never receives the message. ALS does not initially destroy the muscle or the brain's intention to act. It simply dismantles the essential biological bridge required to connect the two. The immediate physical consequence of this severed connection is that the muscles, suddenly deprived of their guiding signals, begin to stiffen, a condition known as spasticity. Without regular use and stimulation from the nervous system, those disconnected muscles eventually shrink and waste away entirely, a process called atrophy. Yet, amid this physical breakdown, sensory perception typically remains perfectly intact. The patient can still see, hear, and physically feel their environment. Cognitive functions and the patient's core personality also remain completely untouched, even as the physical body systematically shuts down all around them. The devastation reaches beyond the physical breakdown. The disease imprisons a fully aware, healthy mind within a progressively failing physical shell. As the disease marches from the limbs towards the body's vital organs, clinical care escalates aggressively, turning basic survival into a daily technological challenge. Swallowing difficulties, known as dysphagia, emerge next. Dietitians first modify meals, but eventually feeding tubes are required to prevent choking and ensure the patient receives adequate nutrition. When speech is lost, occupational and speech therapists step in to deploy alternative, nonverbal communication devices to keep the patient connected to the world. Finally, as the breathing muscles weaken, patients transition from wearing non-invasive ventilation masks at night to relying on full mechanical ventilators. Late-stage care requires constant engineering, necessitating innovative mechanical ways to bypass the body's failing systems to sustain life and dignity. This graph illustrates the grim baseline prognosis. Average life expectancy is 3 to 5 years, primarily due to respiratory failure. However, FDA-approved medications like riluzole, edaravone, and tofersen are now deployed to actively slow neuron damage and muscle decline. Alongside these treatments, the global medical community is running active clinical trials and cutting-edge genetic research, striving to halt the deterioration entirely. While a definitive cure remains out of reach today, the relentless pace of medical investigation is slowly mapping the disease's weaknesses. It offers tangible hope that a future generation will finally rebuild the connections ALS destroys.